Good morning, everyone. Thank you for coming to rounds this morning. As Dr. Chow mentioned, I'm going to be talking about the hepatic vein on echocardiography. And it's if you're like me before this talk, all I really knew, honestly, about the hepatic vein was that severe TR causes reversal of some kind, and that you have expiratory reversal with constriction, I think, and then maybe that it happens on inspiration with restriction. That's really the extent of my knowledge. It's been really interesting going into this kind of like very overlooked part of this standard transthoracic protocol. It's been very, very interesting, and hopefully at the end of this talk, just by covering just the basics, I think that all of us hopefully will leave knowing way more about the hepatic vein than I did when I started. It's a very, very interesting topic. And so we are going to take a nice deep dive, as you can see, into the wealth of info that is the hepatic veins. And of course, there are limitations. Just before I start in hepatic vein flow, it's not easy. You guys are seeing this every day. Sometimes it's hard to find. Sometimes you look and you get this kind of crazy waveform, and you don't really know. You're not seeing anything that's familiar. But hopefully, for the clinicians out there who are listening as well, kind of like the GDP, with maximum understanding of what you should be seeing, hopefully you can derive more and more useful information. And when you see something like this, your gut reaction is, this is like a bad acquisition or something. You ask yourself, what factors could be causing? Why am I seeing what I'm seeing? So we're going to start. Oh, I got to click this one here. Yeah. So to start, we're going to cover just basic anatomy, and as a challenge to those out there who are listening who feel pretty confident about what they know about the hepatic vein, I'll just start with very basic questions. Do you know how many hepatic veins are there? How many are there? What vein are we typically looking at? And here's a question: are there valves? We know that there's valves in the internal jugular, for example, sometimes in other veins. Are there valves in the hepatic veins? Have you guys seen any? So let's dive right in. So the liver has two sources of blood supply. There's the hepatic artery and the portal vein that brings blood into the liver, the portal vein from the splanchnic circulation. And the hepatic vein drains, or the hepatic vein in totality drains the liver into the IVC. And the liver can be kind of separated into these 8 segments that are been described as coinode segments or lobes. And in most people, you have 3 major hepatic veins: the left, the right, and the middle. And in 60% of people, or somewhere between 60 and 80, the majority of people, the left and the middle hepatic veins join together in this common trunk before entering the IVC. So when you're looking at a subcostal, most typically we actually are looking at either the middle or the left in this kind of common trunk in the subcostal view, and because those are typically in line with our ultrasound Doppler as we're looking at the IVC. There are no valves in the hepatic vein. They're a completely valveless system, unlike perhaps some other veins you may see. In addition to these 3 main big ones, you may also see a number of accessory or anomalous veins that sometimes drain in below the hepatic veins. And we definitely see these on TEE. Sometimes you see these tiny little veins that enter in the IVC. These are what we call accessory veins, and they enter the IVC typically below the main hepatic veins. Now, if in your subcostal view you don't see the hepatic veins very well, despite looking, you can actually optimize your view. So if it's been described that if you turn the patient to the left lateral and put your probe directly over the liver, sort of in the midclavicular line, you can actually see a lot. You can change your orientation. You might see the middle vein a bit more better and in line. Now, every once in a while, you'll see this a big floppy eustachian valve. It typically does not affect or impede either hepatic vein flow or waveforms or the IVC waveform. As you know, it typically directs flow as it returns through the IVC. It doesn't impede it. So in summary, kind of the anatomy that you should know: there's 3 main veins that drain to the IVC, and we're typically looking at either the middle or the left in the subcostal view. Okay, so now let's move on into kind of our pulse wave Doppler. And again, some questions I'm going to posit to the audience here is, you've seen the hepatic vein. You might get a sense of what breathing does to the hepatic vein. What do you think Valsalva, when you strain, what do you think happens to the hepatic vein? Just I'll posit that as we start. So the ASC in their most recent comprehensive echo guidelines suggest that the proper way to measure this is you should be you should be sampling about 1 or 2 centimeters up from where the hepatic vein enters the IVC. You should be recording flow throughout the entire respiratory cycle. When you do your color, you should try and adjust the scale so you avoid aliasing. Really, all you're supposed to be seeing is red and blue. You try not to see some of that splashy color. And then you suggest turning on the respirometer. I'm going to say that one more time. Turning on the respirometer is really helpful when you're trying to understand how the hepatic vein changes with respiration. And the other thing that's really helpful when you're trying to get the best and most information from the hepatic vein is using both a minimum speed, which allows you to see changes in respiration, as well as a fast or a medium speed to try and identify the individual waves in better detail. And it suggests that you should obtain this during quiet breathing. Now, as we kind of describe the waveforms, this should look pretty familiar to most people. When I mention or when I discuss retrograde flow, I'm talking about flow that's going backwards into the liver, backwards into the hepatic vein. And anterograde flow will be flow coming down the hepatic vein into the IVC, into the RA. So this is, this is a pretty normal hepatic vein spectral droplet profile. We've all seen this. Let's go into how this is actually formed. So the very first wave in the hepatic vein PW profile is the A wave. This is a retrograde wave of flow, so going backwards towards the hepatic vein, and it's created by atrial contraction. So as the atria contract, you have a rise in pressure in the RA, and that sends a pressure wave backwards in the IVC and up the hepatic vein. The next wave that you get in the profile is this S wave. So this is caused by ventricular systole. When the RV contracts, that tricuspid annulus moves downwards toward the base. That's what gives you your TAPSE. That sudden apical displacement, the downward movement of the tricuspid annulus, is what pulls the RA open. It changes the RA volume, and that sudden drop in RA pressure is what gives you this sort of S wave. This is why you also get a sort of X descent in your jugular venous pressure. And so, because of that drop in RA pressure, you have anterograde flow through the hepatic vein. You get this V wave next. This is a transitional wave or descent, and basically your right ventricle has finished contracting. It's now starting to relax. The tricuspid valve or the annulus is moving back towards the RA. You still have kind of atrial filling into the RA from the anterograde S wave, and so you can sometimes get this atrial overfilling phenomenon where the RA pressure starts to rise, and so that flow from the S wave. And I'm going to try and put on my pointer here if I can. Pointer option. Oops. There we go. Laser pointer. Nice. I got a laser pointer. Okay. So and so as your right ventricle starts to relax, that anterograde flow from the S wave down here slows, and you get this kind of V ascent or flow with backwards. Now the height of that V wave can be either anterograde, it can be neutral, or it can be retrograde. But that initial sort of upwards or anterograde wave after the S wave is called the V wave. Finally, as the right ventricle continues to relax and the pressure inside the right ventricle falls below the RA, the tricuspid valve opens, blood rushes in from the RA into the right ventricle, and that again allows for anterograde flow, and so you get this D wave, which again allows IVC and hepatic vein anterograde flow. So those are the components of your normal spectral profile, spectral dropper profile of the hepatic vein. So clinicians out there, obviously you can see that there are clear similarities between the jugular venous pressure, the JVP waveform, and the hepatic waveform. Of course, the right atrium, is continuous with both structures via the IVC and the SVC. Something to point out, when you're learning about the JVP, you learn that the X wave is deeper than the Y wave, or the X descent is deeper than the Y descent. Similarly, the normal ratio is your S is deeper than your D. Your SD ratio is greater than 1. That's what they say. Now, there are key ways why the JVP and the hepatic vein are different, and by far the biggest difference is that the hepatic vein is intra-abdominal, and that changes physiology actually completely. We're going to get into that in the coming slides, but it's fascinating. Just like the JVP, when you can get this wave here called the C wave. So this is when right at the beginning of ventricular systole, the tricuspid valve snaps shut. That upwards motion of the valve itself and that bulging into the RA, that can actually transmit a little bit of pressure wave backwards. And so sometimes in your hepatic vein, you can see a little C wave. So really, they do look, they are quite similar in normal circumstances. So this is just another summary, which I'll just leave here for online. Okay, now what is the effect of respiration on the hepatic vein? We've all seen this. You guys have been trying to interrogate it while the patient's breathing. When you take in a deep breath, you drop your intrathoracic pressure. So the gradient of flow coming from your hepatic vein and your IVC into the RA, that goes up. And so flow increases. And typically the SD ratio, if you see here, stays similar. So here is a nice picture. This is me, by the way. This is my personal hepatic vein that I'm sharing with you all today. So as you can see, as I take a deep breath, flow increases, and the SD ratio stays pretty similar. Now, here's an interesting waveform. You probably come across this once a week. So this is, if you're looking at this, you might say, okay, where do I start? This is, we don't really have a lot of waves that are going backwards. How do I interpret this? So, just going to change to my presenter view here. So, my approach when you're trying to understand what's going on in the hepatic vein is you have a QRS. That is your guide. So the first thing is you find a structure in the QRS that makes sense and you drop a vertical line. So I see that is a P wave. That I recognize that. So I'm going to draw a straight vertical line and start looking afterwards. As we talked about, the P wave is what generates your A wave. And so the first kind of upwards or anterograde flow is your A. Then everything else should make sense. There's your S, there's your V, there's your D, and that's right on time for the next P wave. And so that's one cardiac cycle. So this, as you can see, is different than what we talked about because all the flow is antegrade. All the flow is coming downward. So this specific image is taken from a patient with this kind of high output state, but you will see this commonly in patients with brisk IVC flow. When you see a lot of flow coming through IVC, typically the IVC is collapsing. It's been described either in high output states or sometimes in patients that just have seem to have either low IVC pressure or brisk IVC flow. The important thing is, as you can see, the SD ratio is maintained. Okay, here's something interesting. Here's another case. So this is a NSTEMI patient who came in, I think it was 2 weeks ago or so. As you can see, there's a little bit of an A wave, but the rest of the waveforms are kind of blunted. They're kind of flat. You don't really see that kind of beautiful up-down, waveform. So you might see this and perhaps for the last little while you see this and say, oh, I don't know, that it just looks strange. So it turns out that a number of things can cause blunted hepatic vein flow and blunting of the waveforms. And a big culprit is reduced hepatic compliance. So patients that are either have fatty infiltration from fatty liver disease, or even in obesity, it's been described as just kind of increased intra-abdominal pressure, kind of making the liver less compliant. That increase in liver tissue stiffness actually reduces the ability for the liver to accommodate that the change in pressure created by the RV or the right side of the heart. You get this kind of uncoupling of hepatic vein flow and the right side of the heart in terms of hemodynamics. When this is sort of most extreme is in cirrhosis. When you have a really fibrotic, stiff liver, you actually get this monophasic waveform. Even when you're pulsing over the hepatic vein, it's just flat flow. You also see that in pregnancy, interestingly, probably related to increased intra-abdominal pressure, although there's still some kind of debate out there. But when you see kind of this pattern, one of the most common culprits is reduced hepatic compliance. Okay, so now for something kind of interesting. I don't know if you guys have ever seen this internet meme. This is it's one around, I don't know, maybe 10 years ago or something like that. As you can see, this nice gentleman here is performing a Valsalva for us. He's straining, and you can see obvious distension of his jugular veins. So when you strain, let's talk about the physiology for Valsalva. There's multiple phases, as you know, but during the strain phase, you're increasing intrathoracic pressure. Because of that, the blood that's trying to flow into the thorax from your internal jugular vein, that gradient goes down because there's now this higher pressure in the thorax, so blood's not draining as easily, and so you get this jugular venous distension. And for the clinicians who are out there on this talk, anybody who's ever tried to put in a internal jugular vein, like a triple lumen or something like that, trying to cannulate the internal jugular vein, knows that when a patient exhales or does a forceful exhale, you get this distension of the jugular vein. So let me ask you, what do you suppose happens to the hepatic vein during Valsalva. Similar structures, both the internal jugular vein and the hepatic vein are extrathoracic, they're outside the thorax. When you do Valsalva, what do you think should happen to the IVC and should happen to the hepatic vein? Well, again, I'm going to share with you my personal hepatic vein. So this is my hepatic vein. This is me before I start my Valsalva. Okay, take a look at this. Let's take a look together. So this is me starting my strain. And now when you look at my hepatic vein, it definitely shrinks. It definitely shrinks. Here it is before and after. During my sort of peak strain phase, it does get smaller. Now, it's not just me. This has been described that during the Valsalva, the diameter of the IVC and the hepatic vein actually shrinks. So why is this the case? Why is this different than the IJ? It's because they're in the abdomen. And not only does intrathoracic pressure increase with the strain phase of Valsalva, but your abdominal pressure also increases with Valsalva. And so there's this squishing effect created probably by the liver that's compliant that compresses the hepatic vein. It compresses the IVC. And so the relative diameters go down. And you can see this actually in this really nice real-time flow of the MRI. Here is the, if you can see there is your hepatic, or that's actually your IVC. And so if I play this, if I can figure out how to play this here, you can see during Valsalva, what happens? Not just your intrathoracic pressure, your intra-abdominal pressure goes up. Your IVC actually almost collapses, and so too does your hepatic veins. So that's kind of interesting. Kind of opposite of what we think with your neck veins. Now, what would happen to the velocity of flow? So increased pressure, we're squishing the hepatic veins, right? So you may think that maybe the velocity goes down. Here is my hepatic vein during strain phase Valsalva. The velocity actually, it probably doubles. It goes up. And the waveforms also get blunted. That's kind of strange. Again, this has also been described, that the velocity of flow, the speed at which blood is coming down the hepatic vein goes up with Valsalva strain. So why I'm explaining all this, number one, I want to add to that Valsalva strain and increased is an example of how increase of intra-abdominal pressure can actually blunt the waveforms. But also there's this interesting phenomenon where the speed of flow increases, and that is not what happens with the SVC. That's what has been described. That's not what happens with the IJ. What's also more interesting, this is me, again, my hepatic vein. Here, I'm doing kind of a partial Valsalva. I'm not pushing down as hard. I just push a little bit, and you get a reduction in speed, a reduction of flow. These interactions are not well described. I don't know why exactly they're happening, but the point of all this is to say that there is some interesting physiology that is applied to the hepatic vein that is not applied to the SVC or the other central veins, even though everything is connected and contiguous with the RA. It's a completely different physiology, and this is relevant during constriction, and this helps you understand what's happening. So we're going to talk about it in a second. But in summary, just to go, we've kind of talked about the normal waveforms, we've talked about intra-abdominal pressure, and we introduced this concept of blunting, why it may not look normal. Think about the liver, think about intra-abdominal pressure. Okay, now we're going to kind of move on to our approach of sort of the abdominal hepatic vein Doppler. There is a ton of different patterns, and there's been a lot of work in sort of connecting different diseases and different disease states with different flow patterns. So there's obviously a lot of them. We're not going to go through each one individually, but just as a sense, what we're going to kind of briefly cover is these are normal patterns. There's a pattern where you have a diminished S wave or almost an absent S wave, true systolic flow reversal, an absent or a small D wave, and a large A wave. And we already kind of covered monophasic flow. So instead of kind of going through each of these, what I'm going to do is we're going to go through the big ones. So we're going to hit tricuspid regurgitation. We're going to talk about atrial fibrillation, constriction, restriction, and then we'll just show a couple of other fun patterns at the end just for interest's sake. Okay. Hepatic vein during tricuspid regurgitation. A question that, again, I'm going to posit to the clinicians out there or people kind of interesting is, we know that, or you may know coming into this talk that, okay, severe TR creates reversal in hepatic vein. So let me ask you, how much TR? How much TR is required to generate flow reversal? Can you quantify that? What does flow reversal look like? Is there early reversal? Is there late reversal? Are there differences in the kinds of reversals? And how does atrial fibrillation affect your interpretation of that flow reversal? So we're going to cover all those things. As I'm sure everyone listening knows, systolic reversal of hepatic vein flow is mentioned as one of the specific criteria for severe TR. This is from the ASC valvular regurgitation guidelines most recently. And the absence of that reversal, or something called systolic dominant hepatic vein flow, is described as a specific criteria for mild TR. It may interest you that the hepatic vein slowly changes as your amount of TR gets worse. So let's take a look at this. Someone has created some grading system for the hepatic vein. This is from Scheinfeld et al. So this is a normal hepatic waveform, as you may have seen. And in patients with mild TR or very little TR, the waveform doesn't typically change. If you can see that the S wave is more dominant than the D wave, or the SD ratio, if you were going to divide them, is greater than 1. Someone has called this as grade 1. So as you start to get more TR, you will notice that your S wave goes down, and the ratio changes between your S and your D wave. So if you think about your RA in your right ventricle, as your right ventricle is squeezing, what's supposed to happen is you have your TAPSE, the annulus gets pulled down, the pressure in the RA drops. But as now you start to dump more and more blood backwards because of regurgitation, the RA pressure kind of rises. And that drop in pressure from the TAPSE is counteracted by this regurgitation jet. And so you start to get this reversal of this S and D ratio. As your TR gets worse, you can actually get full blunting without anterograde flow. So that's described as grade 3. And as you get to even more severe TR, you get this full reversal of your S wave. And so, oftentimes you may not have seen this as much, the full kind of individual waveforms in this patient with sinus rhythm. You have your A wave, then you have reverse S wave, and then you have your V wave, and then you have diastolic flow. And it turns out that as your TR gets worse, or if you develop other problems such as RV failure or AFib, you actually get fusion of all 3 of those waves, and it looks something like this. This is probably a lot more familiar. I'll just point out, and you may not have thought about this or noticed, is that the reversal actually happens quite a bit after systole. It's if I was going to describe this, I would say it's kind of late. The majority of your reversal is happening late after systole. So we'll kind of compare that to some other cases in a second. So here is a nice case here from St. Mike's. We got a patient. This guy's got atrial flutter, but he's got severe functional TR. As you can see here, when you line it up with the QRS, you get this color Doppler showing reversal, and when you do your pulse wave Doppler, you get this very clear biphasic pattern of flow. No doubt about it. You might notice here and say, hey, why does this reversal have 2 spikes, and this reversal has 1, and then this reversal has 2? Well, we'll get into that. This is not an A wave because this patient does not have is not in sinus. We'll get into. We'll come back to it. But the key point here is, you guys have all seen this before. Unmistakable biphasic pattern of flow in severe TR. Okay. Couple of facts here from our research. So there is no specific regurgitant volume that leads to flow reversal. There's no fixed amount, and the reason is there's this complex interplay between other patient factors and what it looks like. So a big one is RA compliance. When you have a massive dilated RA, when you see these huge RAs almost as big or bigger than the LA, turns out that no matter how much volume that you have regurgitating into that right atrium, the actual pressure in the RA may not change if it's big, floppy, and used to being dilated. And so you may not get reversal when you have these big right atriums. If it's smaller or non-compliant, well, then a smaller regurgitant volume may generate enough pressure for reversal. Another component to think about is RV systolic dysfunction. So again, you guys have seen the TAPSE. When you have good RV systolic function, the annulus moves down, and that's what creates your S wave. As you get RV failure, you have less TAPSE. Your TAPSE goes down. You have less apical displacement of that annulus. And so your SD ratio can reverse, totally irregardless of what the TR is doing, if there is severe TR, but you can get this kind of reversal. So let me show you some examples. Actually, this is, there's a number of papers all kind of from the 80s that show that a lot of patients with severe TR don't demonstrate this, clear reversal wave, that there's this, instead you get this blunting pattern. So let's look at some examples. So here's a case. You can see very, very big right atrium. If we apply color, we can definitely see there's a lot of, there is a significant amount of regurgitation. Here's your RV inflow, no question about it. Lots and lots of TR. And what do you get when you pulse the hepatic vein? Not very impressive. Not very impressive. And so by looking at this, it would be incorrect to say, I don't think it's severe because, I don't think it's significant because there's no reversal. It's actually, you have to think about, oh, wow, that is a really, really big right atrium. That's probably hiding some of those pressure changes. Okay, AFib. We all see patients with atrial fibrillation. What is the effect of that on the hepatic vein? Well, as we talked about, the first wave is that A wave caused by your atrial contraction when you are in sinus. So you lose the A wave in atrial fibrillation. Now, because when you think about the atria contracting, it actually works a little bit to pull your annulus towards the base of the heart. And actually, every time you've done your RVS prime, if you notice if they're in sinus, they actually get a little bit of a negative deflection during atrial contraction. You lose that. And so that actually contributes, the A wave contributes to the total displacement. And so a lot of patients with atrial fibrillation, not only do you have a loss of your A wave, but you have a reversal of this SD relationship. We just talked about how supposedly with TR, you get this reversal. Well, with AFib, you get the reversal as well. And it turns out that you have more prominent V waves, or what has been described in literature as a S reversal wave. Unfortunately, this concept of a V wave or the nomenclature is not consistent in the literature, but you can see that right after systole in atrial fibrillation, you get anterograde V waves. And so you may look at this and say, oh, does this count as systolic reversal? It's a reversal that's happening right after the QRS. Well, this is different than that systolic reversal wave created by TR, but you should just note that when you have patients in AFib, you might see a bit more of these kind of transient or transitional V waves. So let's look at a case. This is another case of TR from here at St. Mike's. We have an 80-year-old gentleman. This is severe tricuspid regurgitation treated with a clip. So this is his pre-clip imaging. You can see that this annulus is very stretched. The RS is massive. You can see there's a good amount of tricuspid regurgitation. This is a TE done by, I think, one of my colleagues, Dr. Ruiz. When we got to the hepatic vein, you can see by color there is, really some kind of phasic flow through the hepatic vein. When you pulse, and apologies, this is a little bit of off axis because this is a TE, but you can see that right after the QRS, there is a kind of prolonged period of anterograde flow or reversal, followed by this diastolic whoosh of filling, this kind of to and fro pattern. So I would, this looks like hepatic vein flow reversal. No doubt about it. Lots and lots of TR. So here's the transgastric view as well. So this patient got tricuspid clips right to the sort of kind of AS commissure there, and turns out it was a pretty good result. Only sort of mild, moderate TR residual. I think they called it mild. And now when we look at the hepatic vein, we see a totally different waveform. So let's look at this and interpret this together. A lot of kind of a lot of waves here. Again, if you remember, our approach to this is draw a vertical line at something in the QRS that makes sense. So you can see here I've drawn it right at the QRS. The first sort of negative deflection is your anterograde deflection is your S wave. You have a little bit of a V reversal, and then you have your D. S, V, D. And so you can actually see the waveform has changed. It is not a complete reversal in systole. We've actually restored some of the waveforms. And now, again, looking at this, if you saw that there is this retrograde flow after systole, you would be incorrect to say that, oh, there's clear systolic reversal, there's still some TR. Or, post-clip or post-repair, you can still have some hepatic vein reversal. Not necessarily. This is not the same as what we were seeing before of this large, late systolic reversal, a fusion of multiple waves. Now, looking at this, you may notice, you may say, hey, you know what? Why is this little tiny positive wave occurring immediately after the QRS? You said that the first negative flexion is your S. This patient is in atrial fibrillation. They don't have they don't have P waves. They're not supposed to be having an A wave. So what is this positive wave right after the QRS? So this has only been described in, I think, one or two of the kind of papers that I saw, but there is reference to a C wave being seen sometimes, even in atrial fibrillation. So as that tricuspid valve closes, it bulges into the RA. Even before you get that kind of S wave, you can get an initial retrograde deflection, potentially a C wave. Okay, let's look at some more TR. This is pretty nice. This is from, I believe, last week. As you can see, the patient is, patients I believe, is in atrial fibrillation. There's certainly no P waves. We get this kind of multiple interesting, you can see individual waveforms here. So you have a reversed S, you have a V, and then you have your D. And this is a patient with severe TR. You can see that, again, this patient does not have an A wave created by an atria contract. Okay, let's keep going. Here's another this is kind of different scenario on a different point. So this is a patient coming in with an inferior STEMI and actually a big right ventricular infarction. You can see that, wow, that RV is really not doing too much. If you look at the atria, it's also very dilated and not contracting as well. This patient is in sinus rhythm, and just so you know, he's got a history of atrial paroxysmal atrial flutter with multiple atrial or multiple RA ablations for atrial flutter. So known scarred kind of big RA. So let's take a look at what the hepatic vein is doing. Very, you guys have seen this before. Very difficult. This patient's having a tough time kind of visualizing it on color Doppler because of breathing. We can't see it really nicely, but they're able to get, the sonographer here was able to get a pretty good pulsing Doppler. Okay, let's analyze what's going on here. Oh my God, I can't really see much of an A wave or an S wave. There's this big sort of wave here. What are we looking at? Remember the principles. Look at the QRS, see something you recognize, draw a line. So here we go. This patient's in sinus. I'm going to draw a line right at the P wave. And now I'm going to look for something that looks familiar. And so you might see that, well, maybe that's an A wave. But if that's an A wave, and if this is a V wave, then for sure the S wave is significantly blunted, and the majority of flow antegrade is happening during diastole. So this is a very clear example of someone with significant RV dysfunction. As we talked about, when you have RV dysfunction, that TAPC is reduced. The amount of displacement of the annulus goes down, and so patients with RV dysfunction get this reversed ratio of S and D. And when it's a very severe case, as we saw in our patient, you can actually have almost absence of an S wave because of how little the right ventricle is moving that annulus. And you can see here in our case, if you notice, you might have asked yourself, why is that A wave also so severely blunted if they are in sinus? Well, you can see the atria is really not doing much. This is a patient with a pretty known sick and scarred right atria, and so it's really not generating a significant A wave despite being in sinus. Okay, so to kind of tie all that together and just to kind of to wrap it up, you get this hepatic vein reversal caused by reversal of the S wave. That's what gives you your systolic reversal, and you usually get this fusion of A, S, and V to get this kind of biphasic pattern when you have TR. That being said, the biphasic pattern is a relatively specific marker for severe TR. However, as we've kind of shown, there's this interaction between atrial fibrillation, RV dysfunction, big right atrium or increased right atrial compliance, and TR. They do happen together. These patients often have right-sided disease, and so you do lose some specificity in trying to interpret these waveforms. So you might be asking, oh my God, you presented me this all information. What the hell do I do when I have a patient with TR? Well, I think the safest thing to do is, if you have a completely normal waveform, it looks exactly as it should be with a preserved S and D ratio. This strongly argues against the presence of severe or of moderate or severe TR, or at least significant TR, let's call it. If you have this very biphasic pattern, it's most likely going to be severe TR. But you should think about, as you start to add up all of this sort of interactions, okay, this patient with severe TR also has a big RA. They also have a big RV. You should just be thinking about, why else might there be this kind of reversal? You may not be able to rely completely on this on the hepatic vein waveform. The more sort of issues you have with the right side. Okay, that's a big topic. Okay, so let's keep moving. So now we're going to talk about the second biggest topic, which is constrictive pericarditis. Now, I don't want to, in the interest of time, I'm not going to go through all of the echo findings of constriction. They're all very interesting. They're fun to learn about, both the echo features as well as the clinical features. As you know, all these findings are kind of a result of this inflamed, scarred, thickened, or calcified pericardium. So I'm just going to try and keep it ultra focused on the hepatic vein, and we're just going to focus on the two reasons, the two principles why we have expiratory reversal, the two physiological principles. Principle number one, when trying to understand the hepatic vein and constriction, is that you have an abnormal pericardium that limits end diastolic filling of the RV. In constriction, these patients often have normal RVs. So the RV has great systole, it's able to move your annulus down, you get a nice S wave, it's able to eject blood well. As it starts to relax, the RV pressure drops nicely, the RV is relaxing, it's expanding with blood, and then wham, the RV hits this thick, hard pericardium. It can't expand anymore. It's the end diastolic filling that's reversed. And so even before you even think about inspiration or expiration, if you just follow the normal waveform, what happens in these patients is you have your diastolic waveform as the tricuspid valve opens, blood's flowing to the RV, and then wham, the RV pressure suddenly dramatically rises because the RV slams into this hard pericardium. It can't expand normally as a RV with a compliant pericardium, and you can get this reversal wave. So even before inspiration expiration, you can get this kind of reversal wave, okay? That's principle number one. End diastolic filling is limited by constriction. The second and most important, I think, principle when you're looking at the hepatic vein in constriction is what we looked at with Valsalva, which is that inspiration acts differently on the SVC and the IVC in constriction. They're different, okay? So how does that work? This is my beautiful diagram. I am an artist of what constriction looks like. You have your heart here with this thick border, which is your pericardium. You have your SVC, which lies intrathoracic, and you have your IVC, which is intra-abdominal, okay? When you take a deep breath, and this is in patients with constriction, you have a drop in intrathoracic pressure that's applied to almost all intrathoracic structures, so that includes the SVC. Because you have this thick pericardium around your heart, that drop in pressure doesn't really affect your intracardiac pressure, so there's no real change in the pressure inside your heart. But as we showed, when you take a deep breath, first of all, that pressure isn't really applied to intra-abdominal structures. In fact, there is some suggestion hypothesis that out there that you actually do get a bit of an increased intra-abdominal pressure against your IVC when you inspire. Plus, there's that loss of competitive flow from the SVC. This is why during inspiration and constriction, you have this increase in flow coming from the IVC. It's actually at the expense of SVC flow. And so when you look at, here is a nice hepatic vein Doppler of a patient with constriction. Okay, let's do our thing. We're going to draw a line at a structure that we understand. So I've kind of drawn a white line here, as you can see, sort of on our P wave. The first kind of positive wave that we should be seeing is an A, then we have an S, and then we have a V. And in constriction, you have this really predominant D wave of diastolic flow. And if you can kind of notice, during inspiration, you have an increase. You have an increase in anterograde flow. Now, again, you have some D reversal. Here's your A, S, and your D. Notice how, again, the D waves are really prominent in constriction, just like the JVP. You have prominent Y descents in constriction. You get the opposite effect during expiration, in that the positive intrathoracic pressure, or rather the loss in negative pressure, allows a relatively increased flow from the SVC and relative decreased flow in the IVC due to a combination of either reduction in intra-abdominal pressure, or you now have competitive flow coming from the SVC. And so during expiration, you can see, if I, again, draw my line, ASVD, reversal, AS, you have your D. Now during expiration, you are getting this sort of, the amplitude of flow from your D reverses, and you get more reversal. And you might see this fusion between your D wave and your A wave. And really, when you're looking at it, it's sort of, every time you've seen this, you probably haven't laid out each individual wave, but you get the sense that during expiration, you have this increase of flow. Tamponade, a very similar effect in that during expiration, you can have D and you have kind of reversal of N diastolic flow. The only difference is that typically in tamponade, you don't have as much diastolic filling due to the interaction of the effusion applying pressure on the pericardium at all times. Just like in the JVP, you lose the Y before you die, right? You have a reduction in your diastolic. So let's look at a case. This is again from, I think this is from the archives. You can see here, if you're looking at the LV, there's increased interventricular dependence. There is this kind of swinging of the septum into the LV during inspiration. We have increased tricuspid inflow variation with respiration. And now when we pulse our hepatic vein, we can kind of see, okay, there is some variation. If we do that kind of exercise as we did, we draw a line sort of on a QRS structure that we recognize. We can see that we have an initial negative deflection, that's our S wave. Then we have our D, A, S, B, we have a D, and then we have this increased reversal. Now, again, just by looking at this picture, you wouldn't be able to tell whether it's inspiration or expiration. We actually don't know. And so this is why, obviously, doing hepatic vein interrogation at different speeds, both a fast or medium speed, as well as a slow speed with the respirometer, is crucial in order to really prove that it's on expiration that you have this reversal of flow. During restrictive cardiomyopathy, because you have it's a very different physiology. You have a rigid myocardium, which results in high filling pressure throughout the intracardiac cycle. The inspiratory pressure when you breathe in during with the restrictive cardiomyopathy is applied to both the intracardiac structures as well as the SVC. That gradient of flow between the SVC and the LA is relatively maintained, and so you don't have that increase, this relative big increase in flow from the IVC during inspiration. In fact, all of that blood tries to get into this kind of diseased RV, and you have elevation in pressure. And so that's why with restriction, you tend to get during inspiration, you get diastolic and sometimes even systolic reversal. Typically in these patients, because unlike constriction, you don't have a normal right ventricle. These are diseased, thickened, unwell right ventricles. Your S wave is actually decreased, and so typically the amplitude of your S is reduced and your SD ratio is reversed. That is typically unlike what we see in constriction. So in summary, if you're just going to remember, my objective here was to try and explain that those two principles as to why you see what you see in constriction is the big one is that the intra-abdominal nature of the IVC and hepatic vein lends itself to this weird pattern. It's not the same as your SVC. It's not the same as IJ. There's this abdominal interaction with hepatic vein that you may not have thought about before, and that in constriction it's end diastolic reversal because of the kind of normal RV relaxing and then slamming into the pericardium. Okay, good. We got through constriction. All right. So for the remainder of time, we don't have that much time. I've gone over. I'm just going to quickly show you a couple of interesting waveforms, just for kind of curiosity's sake. So there's been some description as to what do you get with pulmonary hypertension. So in these cases, the RV is typically had time to remodel, and there's an increase in right ventricular end diastolic pressure. Sometimes you get early tricuspid valve closure, and so you do end up getting a reduction in your kind of D wave. Typically is only sometimes seen with inspiration. So you can see here in this patient, we've actually lost the D wave, no D wave there. And then on inspiration, that's when you do see a bit of D wave. During expiration, the D wave actually disappears. And then because you need this higher right atrial pressure to squeeze blood into this remodeled unwell right ventricle, you can get prominent A waves. This is just like the JVP. And just like all things, as we mentioned, there's this interplay between how the RV changes with kind of disease states. Well, when you get RV dysfunction, you also lose your S wave. And so you can kind of have a reduction in all kind of amplitudes of waves. And then if you develop AFib, you're not going to have prominent A waves. You're just going to lose your A waves. And both of those are common with pulmonary hypertension. So just keep those caveats in mind. I'm going to skip COPD for now, just in the interest of time. Here's a case from St. Mike's. This is from 2017. So on first glance, you might say, oh, there's reversal. This is severe TR. Hold on, hang on a minute. Look at the QRS, draw a line where something makes sense. So it turns out right after the P wave, you get this, wow, big prominent A wave. And then you have your S wave, you have a little bit of V reversal, and then you have your D wave. So this is a very interesting case. You can actually see it on color Doppler, where right after your P wave on your QRS, there's this big retrograde flow. Well, when you look at the RV, oh my goodness, that is a hypertrophied, very, very hypertrophied right ventricle. What could be going on? This is an interesting case of a patient with congenital pulmonary vein stenosis. So that RV has had time to remodel, become really thick, really stiff, and then when the RV contracts, you get this really impressive A wave. That's kind of cool, congenital pulmonary stenosis. Okay, here is another interesting case. You might be looking at this and saying, okay, there's a bunch of irregular stuff here. What's happening? We're going to draw a line. That's something we recognize. So here's a P wave. Okay. If we label it, we kind of see there's a bit of an A wave. We have this S wave. Okay. We have a bit of a V reversal. We have our D. And then what is this kind of like slow wave here before the next P wave? What could be happening in this case? And I'm going to share with you another one of my personal hepatic vein pictures here. So this is my hepatic vein at rest. I kind of have the same thing. You have your A wave, you have an S and a D, and then before the next kind of cardiac cycle, you have a little bit of an extra flow. What could this be? Well, it turns out if you are bradycardic with prolonged diastole, your RV's had time to fill. Now the RV pressure starts to rise. You might get a bit of early, your tricuspid valve might close. Sometimes you can see diastolic TR. You might have, you may sometimes see this, but that that kind of late diastolic flow reversal actually corresponds to the J wave or the H wave in the JVP. I don't know if for the cardiology residents out there, the forgotten H wave of the JVP, that's diastasis. And so that kind of late diastolic kind of wave is common when you're interrogating bradycardic patients. Okay. Quickly moving on. Tachycardia, just out of interest sake, when you're very tachycardic, a couple of things can happen. You can lose your A waves. You can see in the top because of how quickly the next QRS is coming. The P wave tends to kind of tends to kind of lie over when your ventricle is relaxing. So you lose your A wave. When it gets really severe tachycardia, you actually only get this kind of fusion of your S and your D wave, and you lose your kind of any retrograde flow at all. Now, in patients with heart block and kind of short PR intervals, this is kind of an interesting case where you can see these patients in heart block and you get these intermittent, big retrograde waves. This corresponds to when you have an atria trying to contract right over a QRS, so the RV is also contracting and the atria cannot compete against the RV systolic pressure, so you get this kind of retrograde flow. This corresponds to Canon A waves on the JVP. That's not uncommon. Here is a similar kind of phenomenon. You can see right at the end of the QRS there's a PVC, and you get this nice, impressive kind of retrograde flow. Vice versa, in patients with a long PR interval, you can get this kind of early S wave due to atrial relaxation at the same time as systolic flow. You can kind of get a bit of an earlier S wave, but when you really have a long first degree AV block, you get this kind of interesting phenomenon where you have your A wave caused by your right atrial contraction, and then there's a little bit of a reversal wave, this kind of atrial reversal wave before your S wave, which is supposed to come right after systole. So you can kind of get that interesting pattern. Okay, there are limitations. We all know this. You might be seeing this and thinking, oh my God, this is way harder than you've made it out to be. It can be very difficult to kind of actually get a good picture of what we're seeing. My patient's really big. I can't see the hepatic vein very well. Patient's not cooperating. Patient's got arrhythmias. Like if you look at this Doppler, you might say, oh my God, what's happening? This patient it's very difficult to interpret. Post-operative patients, they got bandages, patient's breathing. God forbid you have a intubated patient post-cardiac surgery who's on a ventilator and also not cooperating. God forbid you're going to try and get some sort of useful information on the hepatic vein. So there are lots of limitations. The other interesting limitation is, unlike the pulmonary vein, as Basma so well presented recently, there's been pretty limited attempts to try and quantify the hepatic vein, much more than sort of an SD ratio. If I asked you what is a predominant A wave. What is normal? What's a normal velocity? There hasn't really been good attempts to try and quantify this and make use of that, and that definitely limits sort of standardization. I've explained and shown you a lot of different patterns. You might tell me that only really in TR, constrictive pericarditis and restriction, is this useful? All the other cases, heart block, you're going to get an ECG. How is this really useful? And I get it, especially if there's no respirometer. Just to kind of put that plug in there. There are limitations to kind of trying to interpret the hepatic vein, but this is who we're all trying to, we're all trying to strive for perfection. And the fun part about echo is we're this weird marriage of pathology and pathophys and hemodynamics. And I think the more you know, and the more you try and appreciate, we all become sort of better scanners and interpreters. And definitely, I would say, just for a plug for our lab, this last couple of, I think, months, every time we see multiple sweeps, every time we see X plane of a structure, we all get excited in the lab because we're thinking the same thing you're thinking when you're showing us these pictures, which is, what is going on here? What are we trying to find? And so it's, I think, the more you're likely you are to scan with kind of curiosity, the more likely you're going to provide great care, and it's more fun. And I think, I think the more we know about sort of physiology, I think the better information we get. So please also don't swing the echo probes like this. So, in conclusion, I think, just if I was going to summarize this, there's a lot of information that can be derived from hepatic vein interrogation. If you interrogate it slowly with a respirometer at fast and slow speed, that's what you require to sort of derive the maximum information. And then when you're interpreting, don't get overwhelmed by lots of crazy waves. Just draw a line at the QRS. That should help. And then practice. Just try and do it a lot of times, and you'll get better. So thank you very much. Thank you online.